what you can see on here is the I think this is we call it, this is the block. So what we are doing here is the bypass the blocked arteries, which will improve the blood flow to the heart. And in last 10 years we did almost 654 open heart cases. And what different we do here is we call it something called as off-pump or beating heart surgery, in which we don't need the conventional method, in which the surgery is done on what we call as on-pump. So you are seeing that machine here on this one. This is what we call as cardiopulmonary bypass machine or heart-lung machine. So usually the cardiac procedures are done most of them when we put the patient on the cardiopulmonary bypass, then we stop the heart and do the surgery. But beauty of off-pump surgery is we don't need this machine. And the problem, what happens when the blood flows to the extracorporeal circulation or through this machine, there is inflammatory response to that body. So chances of bleeding, infections, and long ICU stays, which were there in the conventional cardiac surgery. In off-pump surgery, we don't use that machine, so all the problems related to the CPP machine or heart-lung machine are bypassed. And so how we do it, so it is a little bit technical challenging because your heart is beating. It's like working on a running machine, you can call it. So your heart is beating, and there are some few instruments we call as a special instrument we use it, which is called as, you can see it's octopus, you can call it. It will stabilize the only area where we are doing the surgery. And on that we do the surgery, and we do the bypasses to all the arteries, blocked arteries. And advantage being, as I told you, the patients will have less blood loss. Actually, we use quite less amount of blood. In some cases, most of the cases, we don't use the blood at all, blood products to the patient. Then ICU stays less. Most of the patients are extubated on the same day, in the evening after doing surgery in the morning. And next day they are shifted out of the ICU. So chances of infections like external wound infections and all those things are less. So patient overall have less hospital stay. So these are the advantage. And another good thing is like we have done the surgery in the geriatric age group also. Like patients now there is because of the increased lifespan, or we have wide range of cardiac cases. Like and because of the cardiac illnesses increasing in the young population, which is alarming, we are getting patients as young as in the 30s. Like we did a case, the bypass on a patient was 37-year-old. And guess what we did? And the oldest what we did is 85-year-old. So our total number of cases we operated who were more than 80 years were there 46 patients, and the oldest was out of this 85-year. And a significant thing, as Dr. Hari said, that because the significant number of cases we are doing because of the back of nephrology department is the patient whose creatinine is high, or the patients who are on the dialysis itself. This strata of beta, because there is very high incidence of coronary artery disease in the patient who are on the who are CKD or chronic kidney diseases. By this time, these patients were denied the treatment because of the risk of, if the creatinine is high, because of the risk of going on the dialysis post-op surgery, or their risk was also high. But because of the team what we have and all those things, we could go through like with these patients, the patients who have who are on the dialysis and they are going under bypass have almost 30% mortality, but in our institute the mortality is up to 5% because they are very high risk patient to go under the bypass. So, and these patients, the kidney patients have most common cause of death is from the cardiovascular event. So I think the message we want to give you that these patients should not deny the treatment because of the because they are on the dialysis or they are have high creatinine. So he was one of the patients. So total patients with renal disease who underwent CABG till now out of this is 108. So we get a quite good amount of cases which are being rejected from the other hospitals or to go under bypass. And out of that, which were on the dialysis or patient, there are almost 9 patients. So which was, as I told you, this is a collective effort, not just of a surgeon, but of anesthesiologist, of the intensivist, as well as the nephrologist. So now I think, yeah. So I will call Dr. Jyoti. She will be presenting the next case from cardiology side. Take over.
Good afternoon. Thank you for making it, all of you. So this was just to create awareness. The thing with cardiac disease is that it is highly treatable. It is the reason why we have deaths is because awareness is not there about the signs and symptoms. Okay, and people reach very late. So that is the reason. But otherwise, we are able to treat majority of patients who reach in time very well. Okay, the technology has improved so much. There are so many advances today, and heart disease can present very suddenly also, seemingly suddenly to the patient, but actually it has been building up over months or years. But patients don't recognize those signs and symptoms, and they end up coming late, and that is why sometimes the outcomes are bad. But why we have this these kind of programs, why we also want you all, means you all go out to the community and you all inform the community that cardiac disease is treatable, and however advanced, as sir said, many cases which are which were thought of as being inoperable have been operated very successfully by Rakesh sir and his team, and they have come out. So at every stage there is treatment available. So that is the message which we need to send out to the public. So now this is one case which I just wanted to, which is a little unusual, so that's why I wanted to just discuss with you all. So as of now, Manipal Hospital, as of today, has done almost 14,000 procedures in the cath lab. We started somewhere in the middle of 2014, that is when our cath lab got set up, almost little after Goa Medical College we started. So as of today, we have reached almost 14,000 cath lab procedures, out of which almost 4,500 are coronary angioplasties. Besides that, we also do pacemaker implantations. Nowadays, we are also doing a lot of structural heart disease. Structural means when the heart valves and all are damaged, and patients are cannot be taken for surgery, or they're very high risk for surgery. We have successfully done those cases in the cath lab. Structural heart disease, also closure of holes in the heart like ASDs, atrial septal defects and all those kind of cases are done. Besides cardiac interventions, for the heart, we also open up other arteries, like for the legs, the arteries going up to the brain in people who have strokes, to prevent strokes. So multiple life-saving procedures are done in our cardiac cath lab, and not only life-saving, it also a lot of disabilities prevented. If we open up the arteries going up to the legs, you are preventing an amputation, you are preventing gangrene, you are allowing that patient to lead a functional life. Okay, with the heart, of course, it is lives, but there are many other interventions which we do to improve the quality of life. And we are also blessed here, by the Goa government, as we are part of the Deen Dayal DDSSY scheme. So we are able to perform a lot of procedures in people who cannot afford it. It's not that it's a private hospital and the charges are high. Our hospital also helps us a lot in making sure that a majority of cases are taken under the Deen Dayal scheme, so the patient doesn't have to pay. The Goan public doesn't have to pay for many of these life-saving procedures which are done in this hospital. And the advantage of being in an organization like Manipal is it adapts very quickly to the newest technology. Unlike sometimes in a government hospital, it's a little difficult to push through or get something that is the newest technology which has come in, because they have a lot of procedural things to that. But in Manipal, we are fortunate to have our management and all, which allows us to bring in the latest technology. And also we have the advantage of Deen Dayal and government support, and we also do a lot of these ECHS cases and government cases which come to us. So now this is just one case which I wanted to talk about. So this I've just put it as a complete cardiac makeover. Now there was this 78-year-old man from Madgaon. He had Parkinsonism, So Parkinsonism it's a neurological disease. So in these kind of cases, the patients are they are people who have tremors, they shake a lot, they are not able to walk very easily. It affects little older people. Now this man had been having Parkinsonism, but he was managing. But somewhere towards the end of 2024, he started having recurrently, parat taka गोड येऊन पडटालो, परत पडटालो आणि त्याचे BP drops जाताले. Okay, so this happened throughout all of, in December 2024. Multiple times he had to be admitted in Madgaon with his physician. Okay, त्यांचे BP सामके down, 60 systolic. He tries to sit up, he falls down again. परत taka, he used to get a head injury because of that. And totally, very dysfunctional kind of life. He was not able to lead a single day without any symptoms. And then most of January also he spent mostly in the hospital where the BP used to drop a lot. So then an echo test was done. Echo test is a scan of the heart where we check the valves and all. So in the echo, what was found that he had a severe aortic stenosis. Aortic stenosis manje kide? So I'll just, so this is the pumping chamber, main pumping chamber of the heart. Ami left ventricle manta. Okay, thaychan pumps down. The blood goes through the main pipeline in the body, that is the aorta. It is like, Salori Dam Chan main pipeline which is going to Madgaon, or Opa Chan main pipeline which is coming to Panjim. It's the mouth of that, so everything has to cross through this. Okay, so when this valve gets damaged, normally it opens and any valve opens and closes, So when this valve gets damaged, okay, it starts getting narrower and narrower. So initially, the heart tries to manage. It tries to pump, आणि थोड़े like after a little more थोड़ा और मेहनत करके just push a little more, but afterwards the heart starts failing. It is like, I cannot handle this. So as the obstruction gets more and more, the heart, after a few beats it just stops. So what happens to these patients? They go down patta. So especially this thing happens when they start climbing stairs and all that. When little bit of exertion also, they just fall down. The BP drops. So that was what was happening to him. So he had the severe aortic stenosis. So all these years, traditionally, when somebody had this valve, tight valve, obstructed valve, there was only one method to correct it. That was by open heart surgery. So that is a major procedure, and this condition is a uniformly fatal condition. Okay, once aortic stenosis, severe aortic stenosis jenna starts zata, that person at the most in all the world studies, if you have no treatment is received, if the valve is not opened within 1 or 2 years, most patients are dead. It is not compatible with life. There is no medicine which is going to change that. Okay, so now we are stuck. There is no medicine, and then he is not good enough for by open heart surgery. He has a neurological problem. Okay, open heart surgery karun te replace karpak. It's a very risky procedure to do an open heart surgery. So now we have a new method, and besides that also, apart from the echo showing the a tight valve, he also had another problem. He had blockages in the blood circulation. Okay, so blood circulation, it is like how you in your house you have a water pipeline, it's supplying your house. His arteries which were supplying the heart also were blocked. There were 2 blocks in his blood circulation. So now he has 2 problems in the heart, and he is not fit enough for surgery. So we used a new method called as TAVI, which is available in our country in the last couple of years only. Okay, so TAVI is that transcatheter aortic valve implantation. Instead of opening the heart and making a cut and removing the old valve and putting the new valve, which was always the traditional, now we go through the leg. Okay, so this kind of a valve is pushed through a wire, just like an angioplasty is done, and we go and put it over here where the old valve is. Okay, we just open the valve with a balloon, just like a balloon angioplasty. Okay, and this valve, this new valve, which otherwise used to be, the chest used to be cut open and the valve used to be placed. That same valve is sent through a small tube, and it is put in the place of the obstructed valve. So this is done just through the groin without even a cut. It's just a puncture wound, just like an angioplasty. So we were able to successfully do that. Okay, and also in the same sitting, his angioplasty also was done. Okay, the blood circulation was blocked. So we have put 2 stents in 2 arteries. So we not only we replaced this valve, okay, we also put 2 stents. So the entire procedure was about say an hour or so. That is all. Okay. So then he was discharged the very next day, and his symptoms had settled. Okay. So he was quite okay. His symptoms had settled. He was very happy. He was able to walk around. He was able to move around. Everything, like able to do. But after 10 days, okay. 10 days later, त्याचे वायफाचे म्हाका phone call येले at around 6 o'clock in the morning. Okay, they are Hindi speaking. So they are Madgaon. They settled in Madgaon for years, but Hindi speaking people. कि डॉक्टर अचानक से आज कल रात तक ठीक थे, आज सुबह पता नहीं क्या हुआ, थोड़ा कंफ्यूज लग रहे हैं, मैं बात कर रही हूँ ठीक से बात नहीं कर रहे. Okay, so then I asked कि then this क्या है BP? Then she was like BP is okay and heart rate कितना है? She was quite wise, the wife. Okay, so she told me the heart rate is 30 beats per minute. And then we knew we are dealing with a new problem. This is an electrical problem with the heart because heart rate has dropped. We have already sorted the valve, tight valve, we have opened up, structural, we have opened up the tight valve, we have already opened up the arteries, they are flowing very nicely. So this new problem is a electrical problem in the heart. Okay, so just like how you have in your house water supply system different, and electrical system different, and your structural different. Okay, so now it was the third aspect of the heart, the electrical issue. Okay, so there was an electrical list which was due to which the heartbeat had come down. So we asked them to come back the same day, and we fixed it the same day by putting a pacemaker. Again, pacemaker is a minor procedure. It is not, there's no major surgery involved. So we put 2 leads inside the heart. Now we do it even without that. There are leadless pacemakers available also. So that was fixed with a pacemaker. So now then he went back home the next day again after a pacemaker implantation. Okay. And then that's the whole thing was that he's a 77-year-old man who was very otherwise extremely sick, okay, and not able to perform anything. But now due to technological advancements that are available to us, we could redress all the issues which are concerning the heart. When there was a structural problem in the heart, we changed the valve, without surgery. Then when there was a blood flow problem in the same patient, we fixed it with an angioplasty, and the electric block was fixed with a pacemaker, all within the short period of time. Okay, so now today he is leading a healthy life. I mean, he has come for a follow-up even a month ago, and he was for 2 months he was there in the USA. His main thing was he had got a new grandson who was in the USA. So I needed that, he wanted to I want to go and see my grandson. So he was able to go for his grandson's first birthday in the USA. So this was done somewhere in February. Means our angioplasty and TAVI was done in Jan, and pacemaker was done in Feb. March he flew off to the US. He spent 2 months over there, spent time with his grandson. And he has come back, he has come for follow-up, he comes walking now, doesn't use the wheelchair, he happily walks into the OPD, walks out of the OPD. So it's the idea of showing this case was just that, everything, it's treatable. I mean, technology has improved so much that whatever is wrong with the heart, most of the time we are able to solve it. So I mean, my other colleagues also have a lot of interesting cases, so I'll just hand over to my other colleagues.
Yeah, Dr. Mukhopadhyay had a few slides to talk about, which he's not available, so I think we'll proceed to the next one. I think we have Dr. Noel who has a few. Please come, Dr. Noel. Which slide onwards shall we? Hello.
Yeah. Today I just wanted to tell you, when we have to diagnose a problem, so normally we start with an ECG, then probably an echo. Many a times when ECG and echo are normal, the next step is to know if there are blocks, is we have to do a stress test. That's the most easiest test. So what if the patient cannot do a stress test, he cannot walk on the treadmill, say he has a knee problem, or he has an ECG which we cannot interpret. So then how do we proceed? Either we can directly go for an angiogram if we think that his symptoms are very classical, or we are not sure whether this is acidity or something else. So in that case, we are doing this special test which is available here. I just wanted to today focus about this test called stress echocardiography. So in this test, we either can put the patient, if he's able to walk on the treadmill, then we put him on the treadmill, or we can give him some certain medications through which we increase his heart rate. In increasing his heart rate, then we do an echo to see how his heart responses to this increased heart rate. So by doing this, we can actually compare his heart at rest versus his heart at peak exercise. So exercise is here mimicked by using a drug, or in some cases where we can put him on the treadmill, or we can use a bicycle. We use a bicycle. But in our hospital, mostly we are either using a treadmill or we are using a drug. The most commonly we are using a dobutamine test over here. And using this, we can check whether the patient has any blocks, and then if he requires, then we can send him for further testing, that is the angiography. So I just wanted to highlight this test, because this test is not easily available outside, so it is done here. Another test which we can also do over here, I think Pankaj is going to talk about.
Hello, and thanks for being here on World Heart Day. So, I'm a consultant nuclear medicine and PET imaging at Manipal Hospital. Again, as Dr. Noel mentioned, we aid our cardiology team with the information that is pertinent to decision making in a case of a heart disease. So, what is our role? Hari, if we can go to first slide. So, basically, we image a heart muscle with the help of a radiotracer. Radiotracer is something which is a radioactive substance which we inject in a patient's body at two occasions. One, exactly as Dr. Noel mentioned, we stress a patient on a treadmill and we try to achieve a certain level of exercise and a heart rate which mimics a physical condition where the patient will be under either a physical or a mental stress. And we inject this radioisotope which is very specific, and it goes and localizes in the heart muscle, that is a muscle of a left ventricle. And we image, once the exercise part of the test is over, we image and we try to see if there is a uniform blood supply to all the muscles of the left ventricle, with which we come to know if there is any compromise in any part of the heart muscle which may be due to the coronary artery disease. So this is the indirect or non-invasive evaluation which we do. We normally do it even before the cardiology team sees the patient, when they have a little bit of doubt in the intermediate risk patients where symptoms may not be classical, like he may come with a chest pain that is not related to exertion or something like that, and we are not certain that he may be definitely having a cardiac disease. In such cases, we risk stratify these patients with the help of this test. And the second scenario is once the patient undergoes, for example, angiography. Sometimes we tend to find a borderline lesions where the lesion is say 40 to 50% block in one of the arteries, and in such scenario we are not sure if we should do a angioplasty or a revascularization procedure. In these patients, when we do this test, we come to know if that partially blocked artery is good enough to supply the heart, and there may be a component of even collateral vessels that may have got developed from the other coronary arteries. So if we find that on the stress myocardial perfusion imaging, if the scan shows a completely normal perfusion at stress, and which we repeat at rest, which is bottom images, which are the bottom images. So if both the perfusion images are normal, then normally these patients don't need intervention. So in a way, we can actually act as a gatekeeper for the invasive procedure. So that is one of the most important application that we have, and we have this facility available only at our hospital in entire Goa. Next, we do second type of imaging, which is called as a cardiac PET imaging, which is mainly done for evaluation of a cardiac heart muscle viability. So what is viability is basically if the cardiac heart muscle is living or not, that we have to diagnose before subjecting this patient to a coronary bypass surgery. So basically what happens is these patients are normally, they have been seen by our cardiology team and they know that the major 3 vessels of the heart are blocked and the ejection fraction, that is the pumping capacity of the heart, is significantly on the lower side. So when such a clinical condition is there, we are facing such a clinical condition, we have to ascertain if a complex procedure like a CABG is going to benefit the patient or not. So what we do is we do a PET imaging. We try to see if the heart muscle is viable or living in a, with the way of injecting again a radiotracer. It is a different radiotracer that we use. It is called as a fluorodeoxyglucose or FDG. It is a glucose analog basically, which goes and again localizes in all the living myocardial tissue. So when we image and when we find out that the myocardium is viable, then based on that report, if the myocardium is viable, then the CABG is planned, and such patients show a significant improvement post procedures in the form of improvement in their pumping function. So this is again a very, very important decision making evaluation that we do, and again PET is available only at Manipal Goa Hospital. These are the main 2 evaluations that we do at nuclear medicine, and we have some other roles which are not very common, but still we have that facility available here, where we use ventriculography for the evaluation of the reproducible ejection fraction in the patients who undergo chemotherapies for the cancers. Then we also use FDG PET for some inflammatory heart conditions, so that is also where we have a role. And there is one very, very rare imaging that we do. We have done about 5 to 10 cases where we do pyrophosphate imaging for evaluation of cardiac amyloidosis. So these are very, very niche but very, very important indications that nuclear medicine and PET comes into picture in overall management of cardiology cases. Thank you so much. Thanks.
Thank you so much, Dr. Kusumathre. Before move ahead with Dr. Nikhil Somdake, I'd request Dr. Divya to please share your thoughts on World Heart Day and how she's a very important, part of the entire
team. Basically, wants to say how I'm going to blow my own trumpet.
Yeah.
So I'm the consultant cardiac anesthesiologist. So my role is in safe passage of the patient through these high-risk procedures. All the procedures that have been mentioned by the cardiac surgeon, the high-end cardiology work that Dr. Jyoti and Dr. Sabyasachi and Dr. Nikhil's presentation, all of them require safe passage because these are very high-risk procedures, and that can be done by the anesthesiology that is administered to the patient. So our patients are very high-risk patients, and these patients have to be taken care of in a very titrated and a very personalized way. Like it's not like one dose fits all and one size fits all. So these patients have to be given some special kind of care, and with very high-end medicines, these patients have a very low therapeutic margin. That is like one small mistake and these patients will not be able to tolerate these procedures. And my other very big role is in guiding the cardiologist and the cardiac surgeon during the procedure. Like the cardiologist, when the procedures the mitral replacement that is done in the cath lab without opening the heart. So that is like done through a keyhole. So where they take the puncture is done through is guided through a transesophageal echocardiography, which is an imaging technique. This imaging technique is completely handled by the cardiac anesthesiologist, where we guide them where they have to take the puncture. The cardiologist is taking the puncture under the guidance of the echocardiography, which is operated by me during these procedures. And also the cardiac surgeon, when we are doing the operation, besides taking care of the patient, I also guide the cardiac surgeon whether the valve replacement has it been done adequately, have we done a complete procedure, is there any post-operative complication, immediate complications which we can correct on the table itself, and whether we have done a complete job, whether the revascularization that we have attempted, has it been done completely or something more can be done, or has it been what we have done is not working for the patient. So what can we do better? All this can be shown intraoperatively itself using this transesophageal echocardiography, which is performed during the anesthesia, which is also done by me. So these are my two major roles. And besides this, I also make sure the patient comes out of the ICU. After these procedures are done, these procedures, like Dr. Jyoti said, it's just a 1-hour procedure. But the patient still stays in the intensive care for somewhere between 24 hours to 5 days, depending on how the procedure is. A cardiac surgical procedure, when there are mixed procedures, they stay for 3-4 days. So how do they have a safe procedure, safe passage in the intensive care area is also taken care of me. So I am a cardiac anesthesiologist and a cardiac intensivist who make sure the patient has a pleasant time while undergoing these very risky procedures. And now over to Dr.
Thank you so much, Dr. Divya. May I request Dr. Legal Sondagate to please take over. He's going to discuss a few milestones that Manipal has been able to achieve over the last years.
Good evening, everyone. I welcome you all for Goa Heart Day 2025. So, you have all known now what different type of myriad procedures we are doing in our Manipal Hospital in the cardiology department, starting from diagnosing conditions with a stress echocardiography, and then doing routine angiography, angioplasties in the cath lab, and ably assisted by our cardiac surgery department, where they are doing bypass surgeries and valve replacement and closing the hole in the heart. Now, where we are going from here, how far we have progressed in the cardiology, interventional cardiology department, is that now we can almost replace all the heart valve without opening the heart. That is to the transcatheter approach, like how we do for the angioplasty. So, but not all patients can be, we can replace the valve, or we can close the leaks of the valve to the transcatheter approach. Those patients who have very high risk for surgery, as Dr. Rakesh has mentioned before, that they require, they have liver problem, they have kidney issues, they have neurological problem, very elderly patients, but still they have a right to undergo the right treatment, they have a right to live. And therefore, these are the very higher end procedures, also known as structural heart disease, which is my keen interest, other than doing routine angioplasty. So I am going to highlight about a case, what we did in Manipal hospitals. It's the first time it is done in Goa. It's, mind you, this higher end procedures don't come under GDSSY because they are very costly procedures. Don't be under the impression that these are basically very higher end procedures, high risk surgical procedures, which cannot be covered under a routine government scheme. So patient has to either spend from his own pocket, they are costly, or they may be having some private insurance. So I'm just going ahead with the case. So he was a 77-year-old male with significant cardiac history. He had undergone a bypass surgery in 2001, multiple angioplasties in 2004, 2011, 2021. He had multiple comorbidities like diabetes, liver cirrhosis, portal hypertension, which was recently diagnosed in November 2024. So how he came across to me, what happened exactly in February 2025, this year, he was admitted with breathlessness and swelling of the feet. And he was diagnosed with a condition known as heart failure, where the heart is unable to pump blood forward into the aorta, which Dr. Jyoti has basically demonstrated before. So in August 2025, his symptoms started worsening, that is, he used to become progressive breathlessness in spite of optimal medical therapy. So he came to me and I did a 2D echo, that is the sonography of the heart, and also had a doubt, so we did a transesophageal echo, that is what Dr. Divya mentioned, is we have to put a probe inside the esophagus, because the esophagus is more closer to the heart, so that we can get a clear view of what is going on inside the heart. And there we came to know that the patient had a severely leaking valve known as mitral regurgitation. So I will come to you what is the leaking valve in the subsequent videos. So the treatment decision was taken. Open heart surgery deemed very high risk due to the age, advancing age, and multiple comorbidities. Family consent for hence, as he was a candidate for open heart surgery, it's a heart team approach. It's not my own decision. We discussed, this is my entire heart team, including the imaging specialist, the cardiac surgeon, the cardiac anesthetist, and a non-invasive person. So it's a heart team procedure, and we discussed with the relative that if the surgery can't be done, then this particular procedure has to be done. This procedure can be done inside the cath lab. It is done in the cath lab where we do our routine angiography and angioplasty. So the family was counseled for transcatheter H2H repair, also known as a tear procedure, using MyClip device. MyClip is a clip which clips the leaking valve. I will show you in the subsequent video. And it is manufactured in India. MyClip is the first recently launched clip which is manufactured in Vapi, India, and is exported all over the world. And we are doing those procedures for you. So the tear procedure was successfully performed on the 6th of September, which is this month only, at Manipal Hospital. First such procedure in Goa, and also in the entire Konkan region. The patient's heart, what was most important that till now, before the availability of MyClip, the only option was to open a heart, put a clip across the leaking valve, and then send the patient home. But this requires a very morbid surgery, high risk. The recovery time is delayed for almost 1.5 months, lung complications and so all. The beauty of this procedure is that patient goes home either in the 3rd or 4th day. There is no incision, nothing, just a keyhole inside the groin. So he was discharged in stable condition within 5 days. So it was a landmark achievement for our entire cardiology team as well as Manipal Hospital. Now we can take such high risk cardiac and patients with advanced non-surgical treatment locally. So this is how the clip looks. I am going to play the video.
The heart is one of the most important organs in the body, working relentlessly to enable the human cardiovascular system to function. The heart has 4 chambers, the upper right and left atria, and the lower left and right ventricles. In a healthy heart, blood flows in one direction through the heart's chambers. Delicate tissue-like structures called valves function to ensure unidirectional blood flow within. The heart has 4 such valves, which regulate direction of the blood flow. The mitral valve separates the left atrium from the left ventricle and is made up of 2 thin flexible flaps called leaflets. When freshly oxygenated blood from the lungs returns to the heart, it enters the heart through the left atrium. Left atrium relaxation causes the mitral valve to open, enabling blood to travel into the left ventricle. When the left ventricle contracts, the mitral valve backflow. In some people, the mitral valve doesn't close tightly, causing mitral valve regurgitation. When the heart beats during contraction, the blood from the left ventricle can flow back up to the left atrium. Mitral regurgitation, MR, can be subdivided into functional and degenerative subtypes. Degenerative MR, or primary, results from anatomical abnormalities of the valve itself. In most cases, the chordae to the papillary muscle rupture or elongate, causing leaflet prolapse. MR is a progressive disease which, if left untreated, can initiate a series of events culminating in heart failure and death. Current guidelines recommend surgical mitral valve repair or replacement in severe MR patients. For MR patients for whom surgery is not an option, minimally invasive procedures are available. MitraClip is a unique, highly maneuverable transcatheter system for mitral valve repair. This procedure avoids cardiopulmonary bypass using minimally invasive venous approach and transseptal puncture to gain access to the left atrium. MitraClip's steerable guide catheter is introduced over a previously placed guide wire. The dilator is used to gradually advance the guide into the left atrium, and the guide wire and dilator removed. The clip delivery system is advanced into the left atrium, positioning the clip above the regurgitant jet and perpendicular to the mitral valve plane. Inside the left atrium, the clip arms are opened to 180 degrees and positioned perpendicular to the line of coaptation before crossing into the left ventricle. The clip is advanced into the left ventricle below the valve leaflets and retracted to grasp the leaflets. MitraClip grippers are designed to drop firmly into the clip arms, securely capturing both leaflets. Once the arms are closed, they create a double orifice within the mitral valve. Prior to clip deployment, echocardiographic imaging is used to assess procedural efficiency and leaflet capture. Prior to deployment, the mitral clip can be released and repositioned for optimal MR reduction. Once achieved, the clip is released and the full system retracted. In most cases, the transseptal puncture and tissue ingrowth between the clip arms increases, facilitated by the polyester clip covering, which promotes healing to create a fibrous tissue bridge between the leaflets. The mitral clip procedure is a minimally invasive, highly effective treatment option for select patients with severe MR.
The clip was put across the leaking mitral. This was all done. This is the animation video, which was for the mitral clip, for the mitral clip position. So what Dr. Divya was saying about the transesophageal echo, this is the one. So you can, yeah. So on the left side of the screen, you can see that orange color. It is all the regurgitating blood flow from the left ventricle into the left atrium. Okay, so these are you can see like a motorcycle silence or something is going across. It should be in the opposite direction. And this is how we do it this is the fluoroscopy. So it is guided with, we have to take the support of the echo as well as what we are doing in the cath lab. So this is how we implant the clip under fluoroscopy as well as the transesophageal echo simultaneously across the leaking mitral wall. What that big probe is the transesophageal probe, which has been done, and this procedure is done under general anesthesia. The clip, this is another transesophageal echo. During the procedure done, you can see the clip, this particular white opaque system is the clip. And of course, very important is the 3D. We can see the double owl eye appearance in the mid. The valve usually doesn't look like this, but when you put a clip, it is separated into two apertures, which looks like the owl eye. So that means the procedure is quite successful and the leakage is completely stopped. So we are very fortunate enough that this was the first time the pressure procedure was done, and we are having the patient also here. I would like to welcome Mr. Tomé D'Souza, who underwent this successful procedure over here, the mitral procedure. Please welcome.
Thank the doctor.
Thank you so much for joining us. Please. You want to stand here?
Good evening, everybody. I thank from bottom of my heart Dr. Nikhil and all his doctors who helped me for my surgery on the 8th of this month. I feel like 20 years younger. Yeah, I couldn't lift my granddaughter from down, Now I lift her from down. I go for a walk every morning 1 hour and evening 1 hour. So I feel much better, and I think God bless you and keep you going with this, okay? Thank you very much.
Thank you so much for sharing your experience. Thank you so much for trusting in us and having the faith in our team to make this possible for you.
Thank you.
Right, so, this is the Manipal Hospital's cardiology team sharing all the milestones that we've been able to achieve over the last so many years. What we intend to basically pass as a message is that while we have so many methodologies, while there is so many things that we could do from a cardiology team's perspective, what's also most important is preventive care. We often forget that, and which is why yeah, hospitals keep launching different health check packages and things. I mean, well, the idea is actually to promote preventive care. We do speak about it at early stage. The earlier that you are able to detect what stage, if there is a problem there, then at what stage it is, the easier it is to treat and to get back to life. So I'd request Dr. Shireen, who is our medical superintendent, to propose the word thanks.
Hello, good evening everyone. I, Dr. Shireen, on behalf of Manipal Hospitals, extend my deepest gratitude to everyone present here, gathered here. Today, we are having a World Heart Day 2025, and the theme for 2025 is Don't Miss a Beat, which is a crucial reminder for all of us that how important our health of our heart is, and how easily we tend to forget given the lifestyle conditions, the prolonged sedentary work that we have, the food, everything. I would like to thank our brilliant team of cardiologists. Thank you so much for your endless efforts, compassion, the dedication you have for the patients. I know today is just one day that we are saying thank you, but it's not enough. And thank you so much for always being there. Thank you for all of the other departments or doctors of other departments who support our cardiology team. Without you, nothing would have been possible. I also would like to extend this thanks to the organizing committee for helping us gather all here. And last but not least, the media, thank you so much for being here, for carrying forward our message of health. Thank you so much.
Well, we missed out on one thing. If there is any questions that you might have, well, they are there to answer anything that you might want to ask. Anybody? Any questions? No? Of course, while we kept saying thanks, we always say what we have done, but to get a live testimony of somebody, thank you so much for making that happen. When we met the patient in the ward, they said we would want to pass this message, not because of as a hospital, of course it looks like an advertisement, but the fact is that if there is anything that is available that can actually save people's life, it should reach people. And it cannot be a better opportunity than today, because on World Heart Day, somebody sharing their life experience and the media being present here. Thank you so much for doing that, and thank you so much.